It's working? Okay.
Hi, we are bringing you a 24-year-old male. He has suffered a severe fall and now he's totally unresponsive.
Thank you very much. Let's start with eFAST. So you have seen really chaotic situation. It's in reality really like it. But I start my lecture with this picture of an orchestra because really, I have to do this. Because the situation in shock room is really not chaotic. Everybody has its role and everybody's trying to save this person's life. Thank you. We have a limited time to act upon, and we need good guidelines to do it. So eFAST is, in our situation, connected with ABCDE system to see circulation evaluation. Before we transport our patient under the best possible conditions, the patient's condition will be assessed through emergency medical doctor. There will be resuscitation, stabilization performed, and in shock room, we are going to detect the potential life-threatening injuries. After that comes eFAST. So we use all types of the machines, and eFAST so shortly means extended focused assessment with sonography for trauma. So we are going to do in short amount of a time really important examination and try to determine whether there is a free fluid in abdominal, pericardial, and pleural cavity, which can lead to consequences. So we are going to help surgeon determine whether this surgery is indicated. Luckily, examination is standardized, so we can all learn it really easily. In FAST, so looking for fluid, we are going also add examination of the pleura, so we add this E at the beginning. As it says, it is carried out soon as possible, and it is so short that it doesn't delay any surgical treatment. There are a lot of indications for this examination. So all sorts of traumas, shock patients or unconscious patient, and there are a lot of questions we are going to answer with this examination. So whether is it fluid somewhere in abdomen? Do we have pneumothorax? Do we think that we have pneumothorax on one side, two sides, both sides? Is there possible pericardial tamponade? So all of these answers with our ultrasound is going to have therapeutic consequences. So we are going to decide, so surgeon is going to decide whether this patient is going directly in surgery, or we have time for CT, because CT is about 30 minutes long. So from the beginning of the examination, transport of the patient to the examination table and back. So it is a little bit longer. What are the facts of this ultrasound? So free fluid is in peritoneal cavity is free to move. So its location depends on the injury and the abdominal pressure. always when the patient lies on his back, the diaphragm is going to suck up this fluid up above. And that's why the most sensitive position where to look for fluid is underneath the diaphragm. So we can already, to 10 milliliters, detect. It is really, really small amount, but you need to be really experienced. In bad conditions, for instance, we have really obese patient or patient has a much abdominal fat or have big belly. So we are going to see it in more than 200 milliliter. Also, one situation when a patient is really metaristic, so you don't see anything in the abdomen. Fresh blood is always hyperechoic, and all of these fluid collections can have different echogenic grades. So it can be anechogenic or echo-free, hypoechogenic, or in this case, hyperechogenic. When we want to play a little bit, we can also later, so not in a shock room, try to estimate the amount of pleural effusion by measuring maximum diaphragm lung distance times 20. We have all sorts of transducers, so which one is the right one? So experienced radiologist or somebody who's doing this examination can perform the examination with all of these three transducers. But we are going most often use this convex transducer because it is possible to look really deep into abdomen and try to depict in best conditions fluid. So sector or linear, they are not so they are not allowing so deep deep located fluid. Overview with schematized ultrasound images. So we are doing this thing here. Order, we are always learning, you need to look at the upper right, lower left upper quadrant and pericardial. It is not really important in which order you are doing it. So ultrasound is always like you see standing on the right side of the patient. That means the whole team is standing here and I have the place here. So most often I will start here. Then when you look at it logically, we are going to try to exclude the most often pathological condition, what is really endangering this patient. So it's a pericard tamponade. So I will do this position, the second one, then this, the third one, suprapubic, our fourth one, and then at the end, pleura. So it is really important to say that you need to practice and repeat this examination. It is like riding a bicycle. So you need just to perform it often enough to be able to do it in short. It should be shorter than 2 minutes. First position, right upper quadrant. So it is here. So what do we see? We see our liver. We see the kidney, we see the lung, so artifacts of the lung. Here is the vertebra. And here, this fatty tissue shows us the Morrison space. So it's fun. We are going to look at the subphrenic space, whether there is a fluid, and Morrison pouch also. We are not going to look at the organ injuries in eFAST. Okay, it is just question of a fluid. So to make it like a scheme, so that's normal anatomy. So liver, diaphragm, this white line, lung, and the fluid underneath, so pleural effusion, a fluid underneath the lung is going to be shown like this anechoic structure here. So we have two examples. So seros, so anechoic pleural effusion, we have liver, we have atelectasis of the lung. And here the structure is a little bit with reflections and hypoechoic. So it is the hematothorax due to bleeding inside of the pleural effusion. Then further on, we are going to look at the subphrenic fluid. So we have a diaphragm here. We have a liver here. It's a colon here. And there is this crescent-shaped anechoic, hypoechoic fluid collection, which corresponds to free fluid. Morrison space, a little bit more easier. So you see the kidney, you see the liver, and this black line, so black structure here, or free fluid in Morrison space. One more time, this is a little bit more discrete. So you have seen, so 10 milliliters, it's a really, really small amount, but you need to find it. Left upper quadrant, also the same thing. So you have a lung artifact, you have a spleen, you have left kidney, and in between this white structures or perirenal fat marks the collar pouch with red is here marked. One more time, like on the right side, hematothorax pleural effusion, subphrenic fluid, free fluid in collar pouch, and no organ evaluation. Okay, we are not losing time on it. Also the same, so normal anatomy and pleural effusion between the diaphragm and the collapsed lung. Here, example, subphrenic fluid. So you need to show the diaphragm, thin white line. You have this small, nicely seen spleen. So underneath is the kidney, and something is interposing between this diaphragm and the spleen. It's the free fluid. Collar pouch, normal. And you see how discrete can this finding be. So this, if you miss it, you are missing probably, so potentially life-threatening situation. Subxiphoid view, we are going to press a little bit on epigastrium and try to show in this manner. So we are looking from caudal to cranially. That means we are going to have a liver like a window. Then comes the diaphragm, and then we see the heart. So pericard has two leaves, and it is really important because between these two leaves, there's going to be fluid. So how is it? It is looking as in reality. So liver, heart, small minimal amount here, but it can be also physiological. I will show you how the pathology looks. So one more with really large pericardial effusion. So we have a heart here. So you see the ventricle here, and here is one leaf of a pericard. And here is the second one, and everything here in between what you see is pericardial effusion. Suprapubic, we are going to do the examination, so in two projections, transversal and sagittal. And it is really important to know that anatomy in women and men is a little bit different. So in women, we have in this area, Douglas pouch, and in men there is a Proust pouch. And we are going to look at it in transversal and in sagittal projection. How does it look like? So we have uterus, we have bladder on front of the uterus, and here is where we are looking for the fluid. So it looks like this. And one more time, so Proust, Douglas, it's the same evaluation for the females and males. Important is to say that there is a pitfall. So the women normally have a fluid a little bit in pelvis due to menstruation. And also there can be fluid due to ascites also. But in eFAST, it's not important just to take it so and think of it. Bladder injury is possible to see, but we are not looking at it in ultrasound. Also here, pathological, how does it look like? So here is fluid in prostrum pouch and a big amount of heterogeneous fluid in Douglas room. Free fluid in transversal, so ventral, dorsal, and here is the bladder wall, here is the bladder, and everything here is free fluid. Position 5, or this part of the eFAST examination. So we are going really high to avoid movement of the heart on the left side. On the right side, we can take it a little bit down, but it's around second, third intercostal space. And what are we going to see? We are going to put our probe sagittally. That means we have one rib, two ribs, so second rib, so it's a like bad sign. And we have pleura, we have chest wall, and then something we need additionally to analyze. On the left side, you see normal movement of pleura. So we have this B lines together with A lines. We're going to talk about it a little bit more tomorrow. But like static image, you see, so thorax wall, you see the ribs, you see pleura, and then the B lines. In M mode, you are seeing the same thing. So first line, subcutaneous tissue, intercostal muscle, pleura, and then artifacts due to lung movement. It is really nicely called seashore sign because it looks like really like a seashore. So we have sky, we have sea, and shore. We can take a cocktail, for instance. What is also important, so when you hear about the lung point, so our students who are learning it for OSCE know it's the axial image of the CT of the lung and lung window. And we see on the right side, so collapse of the lung due to pneumothorax. So this point is the most important point. Why? Because we can show this transition of a normal parenchyma to pneumothorax. It is on the left side, normal sliding of the pleura. So we call it here in German area, so Ameisenlaufen. I find it perfect because it is really how it looks like. So ends running left and right. And on the lung point, you see, so the lung pleura that is not moving. We see the A lines, there are no B lines. And as the patient takes a breath and it is here, so normal lung and normal pleura that is moving. So this point show that point which I have shown you in CT. Schematized, so B mode, pneumothorax, M mode. So that's a static build, but we are image, but we are doing it like in live version. So we are looking actively and just schematized barcode sign. So we are now going to do a live ultrasound examination of the eFAST on my injured patient, and you can look at it. So to begin with, you need to adapt your machine. I usually do it before the patient comes and smear the gel all over the place and determine where is my left side of the where is my left side of the image, so, and where is the right side of the image. So my patient cannot do inspiration, expiration with me. So it's like that. So on the rest, I am starting with right upper quadrant, and I'm going to look like this. So I'm putting my probe in one of the lower intercostal spaces. So I'm going between the ribs. And the things I'm going to see are, so there is diaphragm, there is a liver, there is a kidney, there is a spine, and in between is Morrison space. So a lot of fatty tissue. So the Morrison space is here really virtual and we don't see any fatty tissue. But this image is enough to say on the right side, there is no fluid in Morrison space. So in phrenico-costal recesses on here or between the liver and the kidney. Then we are moving further on. I'm going to look at the pericardial pouch. So here sometimes we have more or less difficulties because, as I said, our patient is sometimes obese and we cannot push so much, or the patient has an air and transverse colon and the liver is so not working like a window. So here, what do we see? I have subcutaneous tissue, I have a liver and a left lobe. This white line here around, it's a diaphragm, and I have here a beating heart. This line here, white line, it's my pericardial sac, and I'm looking for fluid. So I'm going to push a little bit, probe more deeply. So I'm just to try to perform better this ultrasound examination. There is also possibility when I don't see good subxiphoidally, there is a possibility that I take a parasternal view, so transversal, and to look at the heart a little bit better, okay? It's my second chance of this visualization. Then I'm going to move further on the left side and take a little gel. And we need to go really further, wider, further dorsally to try to avoid the stomach filled with food. So I have a diaphragm, I have a lung, I have a spleen, there is a part of the upper pole of the kidney, there is a beating structure, so I am seeing really the aorta here, but it's not important. And here is collar pouch, so also thin white line, and here I will find my fluid. Then I will shift further down, so suprapubic. So I'm going, when we have luck, our patient hasn't peed and bladder is completely full. And in my patient, it is unfortunately completely so empty. So he was, yeah, he was prepared for this. So we are going to look at this structure. So it's a prostate. So here it's a rectum. So here is going to be my fluid. And when we look like this sagittally, so rectum is here. So small bowels, here you see the movements. Maybe a little bit better. The bones of the pelvis, floor, and we are going to look at the fluid here in this area. Okay, so then we are going to do the A part of the examination. We are going to look at the pleura, whether there is pneumothorax or not. So just in this situation, I am going really to do a little bit adaptation to my ultrasound conditions, because I really need to look at this pleura movement a little bit better. And you see this Ameisenlaufen, or so movement of the pleura. B lines, sometimes you see one or two lines, but you see the movement. And then we perform M mode. I hopefully am doing this right or not. Where do I need to confirm? Oh, it's not working.
Okay.
Yeah, okay. So I'm going to then perform M mode. Or this, no. This, no. This, no. No. Okay, it's okay. So M mode at the end. Also, we are going to do it on the another side. So M mode. Yeah. Thank you for the tip, my patient. So it's the typical seashore sign. So you see the movement of the lung making artifacts. You see this thin pleural line. So it's our shore, and above is our sea. Our report at the end is going to be eFAST positive or negative. So happily, in this situation, eFAST is negative. Thank you.
Yeah, thank you very much, Jasminka, for healing me. Jasminka, I have. Can I give you the questions of the audience at first? So let's rotate back. Does anybody have a question?
There are no dumb questions.
Yeah.
Please.
The question was how to differentiate between pleural effusion and pericardial effusion.
So pericardial effusion, you are always going to look where the heart chambers are. And so anatomically, it is between, so surrounded with white structure, what is the parietal leaf of a pericard. So it is just here where the heart position, where is heart position. And pleural effusion, we are always going to look at the left and the right because our patient lies on the back. So due to gravity, free fluid between pleural leaves is always going to fall behind. And pericardial effusion is always surrounding the heart. So just looking at the position and just with thinking, okay, physics, gravity, I'm going to look at my pleural effusion there, and for, around the heart is pericardial effusion. Okay?
Any other questions?
Please. For me, maybe 20 seconds.
So
Yeah, normally is under 2 minutes.
So I repeat the question. So it was the length of the eFAST, so the duration which somebody needs.
Yeah, yes. Okay. So under 2 minutes is everything okay. And you will see as you train and do it more and more often, you are going to be faster and faster and faster and faster. And we are always trying to look a little bit better, find the kidney a little bit better. But when you are experienced, so 1 point, a little bit angulation of a probe, and you have it. So no fluid further, no fluid further. So there are no organ evaluation or something like that. So yes or no further. Okay? Please. Mm-hmm. Mm-hmm. You can repeat it. Okay. Are you going to repeat it?
Do you want to do?
Yeah. So in eFAST, it doesn't matter what's the cause of the fluid. eFAST is always positive or negative. Then we are looking at what is happening in reality. It's a little bit situation that is not so comfortable, but we also know the limitations of the eFAST examination. When we see the patient with liver cirrhosis or something like that, it is going to be at the end, yeah, it was cirrhosis. But this operative indication is not just on the situation of the eFAST, but a patient is also clinically evaluated. So if the patient is unstable, then they are going to perform laparotomy. And when not, we are going to do the CT, try to look for the injuries, and then decide whether this patient is about to be sent to OP or not. Okay. Please. Yeah.
Okay, I will repeat the questions. I thought that you want to repeat them. And the question was how often you do this examination, the eFAST protocol, if you do it with every patient.
Mm-hmm. So we have this beautiful opportunity that in our center, we have really like an institution of a shock room. That means that every patient is going to have the same treatment. Every patient that is brought to shock room, sometimes it's a really funny situation because, for instance, patient had an injury of a finger, paid 3,000, 4,000 euro, and is brought to us with a helicopter, and we are still doing some of the measurements like evaluation in shock room. So everybody is going to have eFAST. So it is on daily basis to be performed every day, so day and night. Sometimes is 1 time per day, sometimes is 10 or more. It depends on the day.
Okay. Yeah, one more question.
Please use the microphone.
Sorry. So in format blocks and literature, it always says that you have to reevaluate a negative eFAST a couple of times, especially in critical patients. Do you have any practical intervals when to reevaluate, and do you actually do it as often as the literature suggests?
So we make it like this. So usually our emergency doctor is going to be first to perform the eFAST. So in helicopter on trauma location or during the transport in transport to hospital. Then we are going to do the second one. So I'm going to do it in shock room, and then we are usually doing CT. So it's like protocol in our hospital, and we are not going back to ultrasound because we can do CT without any problems. So it's in our algorithm. But when you don't have this opportunity, normally you can do it. You can do it in 5 minutes, 10 minutes, 3 hours. It depends on the situation of the patient. So you need to talk with in anesthesiology and just make an agreement upon the case. Okay.
Okay, so I guess that has been it.
There is one more question from our online audience. The question is, when is it obligatory to perform a CT scan after eFAST?
Sometimes, you have a radiologist point of view and you have a traumatologist, anesthesiologist point of view. So, but mostly we are okay with the decisions. So the patient is going to have this examination CT when the patient has a polytrauma, so more, suspect. So when more injuries, so more organs are to be injured, or when we have a patient that is unstable, or in the patient that is unconscious, when patient had, for instance, blunt abdominal trauma, when the patient had, for instance, so trauma in the chest area, and we don't know so how much is the pneumothorax, is it tension pneumothorax. So usually we perform sometimes radiography, and then immediately in shock round there are drainages, and then we are doing CT. So I can say that in 95% of our patients, or even more, we are performing CT with CT protocol. That means from head to pelvis or lower due to injury. Sometimes it is negative, but we need to be sure, because some injuries are really hidden and the patient is young and really well compensated, and in 2 hours he crashes. So we lost 2 hours of his time. So we are doing like this systematically. Almost every eFAST is leading to CT. Okay.
Okay, then thank you again, Jasminka.
Thank you very much.